I'd first like to thank Dr. Adrian Goh and the SASO committee for inviting me to be part of this exciting workshop. And special thanks to the organizers. The lunch was fantastic. I don't know about you, but I'm still trying to digest it. I'll be sharing today a little bit about using the OCT angiogram for anterior segment in the cornea. Now we know that the OCTA is still and originally designed for the retina, but we managed to sort of adapt the system for the cornea, and I'll be sharing a little bit about our results. So we all know OCT essentially is an optical ultrasound, and by measuring the light reflections from within the structures of the eye, we are able to image structures, cross-sectional views of the cornea, as well as the retina, and structures within the anterior segment. And I think why clinicians are excited, or at least why we're all here, is because for the first time, OCT doesn't just give us information on structure, but it now gives us an idea about function as well. And we managed to use the same system software to visualize vessels within the cornea. And the principles are pretty much the same. Bright areas represent areas which suggest change or fluctuations when comparing two sequential OCT scans. Black areas just means that the areas have little or no change. And of course, it's a lot more complex than that. It involves algorithms and statistical analysis to give you the final image as you see here. And I'm sure the previous speakers have already gone through the principles of OCT angiography. And I'll just touch a little bit on it because we'll be talking about the limitations of OCTA, specifically in the anterior segment. So essentially, motion is detected when there is a speckle or a discrete area of constructive interference from reflections of a moving object or a group of moving objects. For example, red blood cells through a nervous cell. It can also detect phase changes, such as fluctuations or changes in the waves of light, much like when you see waves in the sea. And if the next wave is out of phase with the previous wave, that is detected as a change. Now, I think we all know now that there are different systems use a combination of measuring the amplitude changes of the phase variances to give you the advantages and disadvantages of each. So I won't go into technical details of that. We also know that it is an emerging market. AngioView was first to market. We also have the TopCon DRI, which is a swept source version of the OCT angiography, the NIDAC and the Angioplex, which was just launched in April last year, and the Heidelberg, which is coming out very, very soon. So back to the cornea, which is quite far from what you guys are probably interested in. We know that corneal vascularization affects a large proportion of people. Statistics include 1.5 million people a year developing abnormal corneal vascularization in the US, and it can lead up to 15% of these can develop blindness from corneal scars, limbal keratopathy, or ocular surface disease. And any insult from infections such as herpes or infections in the developing world such as trachoma leads to significant corneal vascularization. And we know that corneal vascularization is indeed a major risk factor for corneal graft failure if the patient requires a transplant. And thanks to the early work of our pioneers back in the 80s, many have used FA and ICG to delineate normal limbal anterior segment vasculature. But we all know it's time-consuming, invasive, and technically challenging, even more so for the anterior segment. And so its use in our clinical practice as anterior segment surgeons or cornea surgeons is very, very limited. I'm sure you guys hardly ever see ICG angiography for the anterior segment. Some people have continued their work from a research point of view. This group is from Liverpool, UK, and they have used ICGA to try and study normal limbal vasculature to look at the potential of studying ocular surface disease. So I was fortunate enough to have access to the pre-commercial prototype of the AngioView back in 2014. This was while I was at Northwest in London, and there was a lot of hype at the time when it first arrived, and everyone was using it for the retina. But we sort of played around with the machine and managed to get pretty decent images of the anterior segment. And we started with 6x6 scans, and we scanned just normal individuals in 4 quadrants of the corneal limbus. And you can see over here, just a blown up picture, these actually represent normal limbovascular loops, or what corneal surgeons like to call the marginal corneal arcades. And in about 20 subjects, we also did some image processing to try and enhance the vessels after they've come out and reduce the amount of motion artifacts described in the paper that's been seen. And we were quite surprised to find that actually it was quite repeatable with a decent signal strength, and we could actually measure the vessel diameter, fractal analysis, and certain parameters which are comparable to studies that have been done using ICGA. We also compared between temporal versus nasal, superior versus inferior, and we didn't find any much difference except for the fact that there were actually less limbovascular loops consistently in the nasal compared to temporal. And we don't really know why is that, but it's never been described before. But we kind of guess that it might explain certain pathologies which are more common in the nasal part of the limbus, for example, pterygium. So in summary, the results from our early phase 1 study were quite promising. It is indeed potentially a rapid, non-invasive form of imaging for corneal surgeons today that potentially gives you good repeatability and image quality. But of course, we needed to do more studies. When I came back, I had access to the DRI, which is the top-down system. And again, by playing around with the system and adjusting the focus, I managed to get some decent images of the limbal as well as episcleral, conjunctival, and corneal vessel, and with decent repeatability as well. But that we are continuing to do more studies using the DRI. And the main difference is the DRI is a swab source. It gives us more information in a much smaller area, but it also has some drawbacks, which I won't go into much detail today. So how about eyes with pathology? That was our next question. And we looked at 20 patients with abnormal corneal vascularization, mainly secondary to infections or previous infections. And we used the anterior view to delineate as well as try and quantify the amount of vessels that can be detected by the machine. What's really useful to us is the fact that we can now combine both the on-fast views of the OCT as well as the on-fast OCT to delineate the vessel as well as the associated corneal scar. So for example, you can see in picture A, it's a patient who has a very large corneal previous infection that led to lipid keratopathy and a large feeder vessel. And we are now able to use the on-fast views, which is on the left, where we can see the size as well as the extent of the lesion, or planning for example, a deep lamellar keratoplasty. And we can also look at the depth of the feeder vessel, where we want to plan fine needle diathermy. So these have all useful clinical applications for us. Of course, there's a whole other wide range of clinical applications, and I won't go into much detail because we're going through some clinical cases tomorrow, but just briefly, on the top, you can see A and B. It's a patient who has an active keratitis secondary to mixed infection, fungal as well as bacterial, very, very early, and we are hoping to look at the progress as well as response to treatment as the vessels regress, as the inflammation reduces. And of course, corneal graft failure is often associated with extensive vascularization, and this was an unfortunate patient who had a deep anterior lamellar keratoplasty and defaulted treatment and came 6 months later with extensive vascularization. So, these are all possible clinical applications that we can use. This is another patient with lipid keratopathy and multiple feeder vessels, which we were treating with anti-VEGF subconjunctival injections. And on the bottom, left and right, you can see patients with a patient with limbal stem cell deficiency secondary to ocular rosacea. And what's interesting is that you can actually see a lot more damage of the limbus than you would see normally on slit lamp examination. Common things we tried an image as well, pterygia. You can see on the right-hand side the nice vascular loops of the fibrovascular growth, and in the bottom left you can see a patient with hepatic keratitis and some abnormal vessels growing into the corneal lesion. And again, just one last example of a patient where you can use both the on-fast views as well as the cross-sectional views to give you an idea of the incursion of the pterygia as well as the extent when you're planning surgery. We're also looking at ocular surface disease, patients with chemical injury, Stevens-Johnson syndrome, even contact lens overwear often develop really abnormal vascular corneal vascularization, and we found that OCT angiography was pretty useful. So in summary, it seems that the OCT angiography, even in its current state, as it's designed for the retina, might be adapted for use in the cornea and anterior segment. We can delineate abnormal corneal vessels, guide fine needle diathermy treatment, monitor response, as well as look at ocular surface diseases. I have to also talk about a little bit about ICGA, because ICGA is still performed in some centers in the world, and this was just accepted last week. This is we compared. It was very difficult to find these patients, but we found 8 patients where they had required ICG angiography of the anterior segment. So you see beautiful, the top, you can see beautiful images of ICG angiography with late leakage, and the OCT angiograms matching the lesion as a snapshot. And we looked at early phase ICGA images compared to OCT images, and we found that actually the vessel measurements and the area of vascularization measured by both systems were pretty close. The OCT angiography tends to overestimate the size of the vessels, but I won't go into much detail on why that happens. So just a comparison for the anterior segment, and this probably is quite relevant to the retina as well. The OCT now provides us a non-invasive option to quickly image the anterior segment and the corneal vessels. It gives us a 3D cross-sectional view as well as on-fast view of the lesion as well as where the vessels come from. It is a static image, not a dynamic image over time, but that's not necessarily a bad thing for us, at least. And we don't really need to look at leakage. We can't tell the difference between arteries and veins on the OCT angiograms as currently, but that might change as the technology improves. And I think the main limitations right now is there's very limited field in the cornea, and it's a lot lower resolution than the ICGA. So just to finish off, I just want to, while it sounds all very, very promising, there are some current limitations of OCT angiography, especially in the anterior segment. The image acquisition can be difficult. There are some interesting properties of the eye, and I'll show you some examples later, which will block the signal, just like in the retina. There are projection artifacts. Eye motion is a huge problem for us as well, and there's a lot of improvement required in terms of the image processing and display as well as segmentation. So issues with image acquisition, very quickly, there's a lot of trade-off between the field of view, scan density, image quality, and speed of acquisition. And we all probably understand the difficulty trying to balance that all out. And for example, this is a patient with a corneal scar, and as a clinician, I would like to know where are the vessels coming from, so that perhaps I could institute some treatment. And here's a 6x6 scan, which gives you kind of a big picture, but not really detailed enough in terms of the vessels, and a 3x3 scan, which gives you a lot more detail on the vessels, but a lot of motion artifacts. There are also intrinsic properties of the eye, just like in the retina. If you have a dense cataract, you won't be able to see the vessels very much. So this is a patient with a dense corneal scar, and if you look at the slit lamp, you probably couldn't see much vessels in the paracentral region. And in ICGA, you can see the vessels beautifully. But the OCT angiography or angiograms, they don't look so good, because there's a lot of block signal from the skull itself. There are a lot of projection artifacts. This is a patient with a scleral nodule, and we can't really see the vessel. I mean, it's not very, very clear at all, but you can't really see the vessel underneath, and you kind of see some wispy vessels, which you don't really know whether it's a reflection of the tissue that's just above it. So that's an issue, and that can be got around by looking at the segmentation layers. A lot of us have to deal with the motion artifacts, and it's exceptionally bad in the anterior segment. So all the images that you see before are beautiful, because those are the images that I could get them without motion artifacts. So I won't lie, it's not a easy thing to get. And here's a patient with Boston keratopprosthesis. I walked into my clinic, and I was like, oh, this is fantastic. I'm going to get really nice OCT angiography images to show people, because you can see all the vessels. But unfortunately, because of the titanium backplate and the PMMA lens, just so much distortion, there's just no way to get any nice vessels on the graft itself. But surrounding the graft, the vessels come up, and that's to do with the signal and the reflections of the signal from the PMMA and titanium backplate. So a lot more to improve. And finally, last but not least, segmentation is a huge issue in the anterior segment. Here's just a typical, if a patient walks in and I don't really get the patient to focus, typical motion artifacts, full of segmentation. Segmentation lines are everywhere, and you can't get a good image. So I think the practical challenges for both the retina and the anterior segment for OCTA A is dealing with the distortions, the blood flow, how do you interpret the images, the speed of acquisition, and how do you actually interpret the measurements? Are you overestimating or underestimating the vessel density and size? Nonetheless, it is still, in my opinion, as a potential replacement for an invasive imaging technique, which we hardly ever use for the anterior segment. So it's quite exciting for us as anterior segment surgeons, because right now, we can now just send a patient for a quick non-invasive scan and just have a quick view of the vessels in the cornea. And I'm sure we all understand that it's still in its early developmental stage, but we can use it to probably identify or understand a little bit about the physiology and the pathology of the cornea. I'd like to thank my research team at Moorfields, as well as my local team in SNEC, OptiView for the logistical support, and last but not least, Mandarin Optometric, which helped to organize this course, as well as support us in terms of providing the angiography here. Thank you.
Any questions?
Nobody's interested in the cornea. I feel very left out right now. Is anybody interested? Anybody do anterior segment work here at all? I guess not. Thank you. Don't feel so low now. Okay, thanks very much.